From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to this podcast from JAMA Cardiology. This is Dr. Robert Bonow, Editor-in-Chief of JAMA Cardiology, and we're going to have a very interesting author interview on a very timely topic of atherosclerotic disease in people with HIV. We know this is an accelerated form of atherosclerosis. It occurs in relatively young people who may otherwise have very few risk factors for cardiovascular disease. And today we're going to be discussing an embedded substudy of the REPRIEVE trial, which was a study of statin therapy in individuals with HIV, showing a dramatic reduction in adverse cardiovascular effects in patients randomized to Pitavastatin. So with me today is Dr. Michael Liu. Dr. Liu is the co-director of the Cardiovascular Imaging Research Center in Radiology at the Massachusetts General Hospital, associate chair of imaging science, and associate professor of radiology at the Harvard Medical School. And importantly, he's also co-PI of the REPRIEVE trial. Welcome, Michael.
Thank you, Dr. Bonow.
Great to have you here today. And also joining us is Dr. Matthew Feinstein, who wrote a very important and complimentary editorial commentary to go along with the presentation from Dr. Liu. Dr. Feinstein is Associate Professor of Medicine, Pathology, and Preventive Medicine at the Northwestern University Feinberg School of Medicine, where he is also a translational scientist investigating inflammation and cardiovascular disease. Welcome, Matt.
Thanks for having me. Excited to talk about this topic.
So this is really an interesting mechanistic embedded substudy of the REPRIEVE trial that we're publishing in JAMA Cardiology. And Michael, it would be helpful perhaps for the listeners for you to first give us a kind of an overview of the REPRIEVE trial and what we learned from that important study published last year in the New England Journal of Medicine.
Sure, yeah, I'd be happy to. So REPRIEVE was a multi-center phase 3 randomized controlled trial enrolling 7,769 people with HIV and low to moderate risk of atherosclerotic cardiovascular disease around the world. Those participants were randomized to pitavastatin calcium 4 milligrams a day or placebo. And the main outcome of REPRIEVE was that over a median of 5 years, there was a 35% lower incidence of major adverse cardiovascular events, including myocardial infarction and stroke, in the pitavastatin arm compared to the placebo arm. Furthermore, that reduction was greater than what would be anticipated just based on LDL lowering alone. And, the reason that's important is because we recognize that people with HIV have a higher risk of cardiovascular disease and that it develops earlier than in people without HIV. But at present, the current guidelines, at least from the ACC and AHA, recognize HIV as a risk enhancer, but there are not specific recommendations for these low to intermediate risk patients, whether they should be getting a statin or not. So in November, actually, the first guideline in response to REPRIEVE came out. The British HIV Association released a recommendation that persons with HIV, age 40 and over, should be on a statin. So that's the first guideline that I'm aware of to have been based on the results of the REPRIEVE trial, and there may be more to come soon.
Yeah, very nice summary. And of course, we could get more into the innards of the parent trial, Michael, but what we really like to get into then is the mechanistic observations you made in this pre-specified substudy of REPRIEVE, where you're really getting at in close and upfront look at the coronary plaques in patients with HIV, with or without pitavastatin. So tell us more now about this really intriguing novel paper that you're publishing in JAMA Cardiology for us.
Absolutely. Yeah, so the REPRIEVE mechanistic substudy was an embedded study including 31 sites from the United States that were also participating in REPRIEVE. And essentially what we did is we took 804 REPRIEVE participants, and these people had additional testing. They had a coronary CT scan when they enrolled in the study, and then on 2 years of either pitavastatin or placebo. They also had various blood measures of inflammation and immune activation taken again at baseline, at 4 months, and then at 2 years. And the goal of the sub-study was to try to explain the anticipated reduction in MACE in this population. So are we seeing changes in coronary plaque, reductions in non-calcified coronary plaque? That was the primary outcome. Reductions in non-calcified coronary plaque progression, and whether those changes in plaque were associated with reductions in inflammation and immune activation.
Yeah, so the REPRIEVE trial told us that there was a striking reduction in adverse atherosclerotic events. And your study is then going to be telling us whether there are changes in plaque as well as changes in inflammatory markers that are associated with those outcomes. So I think the nidus of your study here is really important in trying to get into the really striking results you found in REPRIEVE. Matt, what was your take-home message from REPRIEVE and why you feel this is an important sub-study?
Michael hit it right away, which is the effect size we saw in REPRIEVE was pretty substantial and honestly, I think surprising. So based on the amount of lipid lowering we saw, specifically LDL lowering we saw in REPRIEVE, we would have anticipated, if we were extrapolating from historical clinical trials, we probably would have anticipated about a 15 to 20% relative risk reduction. And we saw a 35 or so percent relative risk reduction in REPRIEVE in terms of risks for the cardiovascular endpoint. So, the next question is why? And I think that's what's so exciting about this study, by Michael, by you, by the whole team, is this starts to get at that question. And I think we still don't know. And certainly one of the leading hypotheses is inflammation. But then the question is, what do we mean by inflammation? Where is the inflammation happening? What is this lipid-derived inflammation? Is this quote-unquote lipid-independent inflammation? And I mean, that's what's really fun to talk about, think about, and potentially also has implications for how we start treating inflammatory risk in particular, along with kind of lipid-related risk in both primary and secondary prevention.
Great, Matt. So, Michael, then give us a little more insight into the results of your study.
The main result in REPRIEVE was that in these participants, the Pitavastatin arm had a 7% greater reduction in non-calcified plaque volume compared to the placebo arm. And when we look at plaque progression, which we defined as plaques getting bigger or new plaques, there was a relative risk that was 33% lower in the Pitavastatin arm compared to placebo. So that was the primary result of the trial. The 33% reduction in plaque progression, perhaps a coincidence that it's similar to the 35% reduction in MACE seen in the overall trial. So LDL lowered as you would expect, and it was a similar amount of lowering as in the main trial. There were also reductions in oxidized LDL, LPL, PLA2 as well.
So that was, I think, the other aspect of your study that was really intriguing, Michael, in that you were not only looking at changes in plaque composition and plaque volume, focusing on non-calcified plaque, kind of the vulnerable plaques, but you've also measured both systemic markers of inflammation as well as those markers that may be more lipid-related, oxidized LDL and lipoprotein phospholipase A2, which are very inflammatory as well, kind of at the plaque level. So tell us more about the changes in the biomarkers and what they might tell us regarding the mechanisms for the changes in plaque.
So yes, we did see significant decreases in oxidized LDL and LPPLA2. I think interestingly, though, there was not a large decrease in high-sensitivity CRP. And I'm kind of tempering that wording a little because there was actually a little decrease. If you look at the CRP levels in month 24, they were lower in the Pitavastatin arm than the placebo arm, though when you look at change from baseline, there was a trend. Also, if you look at the 4-month CRP, there was actually a larger decrease in CRP in the Pitavastatin arm at 4 months, but then that got attenuated out at 24 months. So why was that? We did expect to see a larger decrease in CRP. And I think one of the reasons was that the baseline hsCRP was not that high. It was about 1.8 mg per liter, both arms, which is sort of in the intermediate range. So that may be one of the explanations why there wasn't a large decrease in hsCRP. I think one of the other interesting things with the biomarkers is that, in fact, the immune biomarkers, we did not see a significant decrease with those immune biomarkers. So, at least on a systemic level, that did not seem to be the driver behind the changes in non-calcified plaque volume that we did see.
Thanks, Michael. Matt, now in your editorial comments, you do make the point that there could be something special about people with HIV regarding their dysregulated immune system that may put them at higher risk of not only atherosclerosis, but the inflammatory mechanisms underlying atherosclerosis. So how do you interpret the biomarker changes relative to the changes in plaque that we saw in the sub-study?
It's a really good question. And I mean, it's a fun study to interpret because, so what do we know? We know that people with HIV, even when their viremia is reasonably well controlled, and even if they haven't had a dramatic CD4 decline and have had some reasonable degree of CD4 recovery, there is still some degree of chronic immune dysregulation, which is marked by a shift in the T cell repertoire, but also a shift in a little bit more of a bias towards monocyte activation and monocyte-related inflammation, all of which you would expect to result in increased systemic markers of inflammation, which, I mean, certainly a number of observational studies in people with HIV do tend to show elevated markers of systemic inflammation, although the specific markers vary somewhat by the cohort studied. But so that said, we think, okay, fundamentally, people with HIV in general tend to have more of an inflammatory milieu than people without HIV. But then the questions are, where is the inflammation and how is that going to be modulated by various therapies? And that's where this gets really interesting, because prior to reading this paper, one would expect to see, okay, there was a 35% relative risk reduction, almost twofold higher than expected. That is probably relates to some degree to residual inflammatory risk. So I would expect to see some reduction in inflammatory biomarkers. And we didn't really see that here, which is, again, it's interesting. Then again, the caveats, I think, are a couple of fold. You can still have a reduction in atherosclerosis relevant inflammation without necessarily seeing it in some of these biomarkers. And I think a couple of things. One is this study, this is a sub-study of the parent trial. So this was, what was it, Michael? It was about an eighth of the overall trial population. Is that about right?
Yeah, it's like 800 versus 7,800. So
yeah,
something like that.
But that said, it still seemed fairly reflective of the overall trial population. So because of that, I mean, there were the confidence intervals for some of the inflammatory markers are maybe a little bit broader. So maybe that decreases the ability to see a significant association. But for a lot of them, there wasn't a significant numerical difference either. So the question is, if inflammation is playing a role, which I think it's certainly still possible it is, you saw a reduction in non-calcified plaque volume and you saw a really robust effect size, then how could it be playing a role if we don't see that reflected in the inflammatory markers? And I think one possibility certainly is that you're seeing arterial retained lipid related inflammation that is being reduced without necessarily being reflected in systemic biomarkers. That's one possibility. Again, it's surprising. I think it's certainly fodder for more discussion and more thinking about why are we seeing this robust residual risk reduction.
The other thing which was intriguing for me as more of a general cardiologist was that we all know that statin therapy can increase the amount of calcified plaque. And so what was interesting was that the reduction and lack of progression of non-calcified plaque was not associated with an increase in the calcified plaque in the treated group compared to the control group. And so what it appears to show us is that pitavastatin was reducing the amount of non-calcified plaque and preventing the formation of new plaque, not that it was just converting the non-calcified plaque to calcification. So that's really striking also regarding the preventive aspect of this therapy in reducing the softer plaques, non-calcified plaques, and also preventing new plaques from forming. Is that an appropriate interpretation, Michael?
Yeah, I think so. So, I mean, that, certainly the reason we focused on non-calcified plaque is because we think that's the biologically active component of plaque that's more likely to rupture and cause acute events. So going into this, my thought was probably you'd see conversion of non-calcified to calcified plaque, which, at least in the results we saw, that was like a minor contributor. I think, we'll be looking at this a little more carefully because We're humans and, we have to categorize things. We define non-calcified plaque as plaque with a Hounsfield unit attenuation less than 350 and calcified over 350. But in fact, really the whole thing is a continuum. And there are plaques less than 350 that probably have some of those plaque voxels, probably have some calcification in them. They may be higher in attenuation than other parts. So there may still be more going on, even though, with the strict categorical definition, we didn't see much change. Another point too, we did measure low attenuation plaque volumes. So that's plaque with an attenuation less than 30 Hounsfield units. That's thought to be particularly bad. Several recent trials like the EVAPORATE trial and Scott Hart study have pointed to that as particularly bad plaque. So that also did decrease. But I think perhaps there's more to look at the plaque composition. And, that's really one of the great things about CT and about this trial is that you can actually see the plaques and how they change over time. And looking at that, and also to Matt's point, one of my colleagues has an R1 to look at pericoronary inflammation, looking at the fat around the coronary arteries and seeing how does that relate to whether the plaques progress or not, or get more calcified or not. I think that'll be really interesting to look at.
Well, there is a great interest now in perivascular inflammation. So I think that would be a nice follow-up to this study, as well as the others that you've got planned.
And that's pretty exciting, the perivascular inflammation component too, because these plaques are active from an inflammatory standpoint, and then underlying that inflammation, what does that mean? It's really an immune response to something, and in a lot of cases, lipid. But also looking at the pericoronaries and pericoronary inflammation, that actually starts to get into some of the actual immune trafficking that's going on and sort of actively involved in kind of dynamic changes in plaque composition and plaque. I guess vulnerability is probably not exactly the right word I'm looking for here. But yeah, that's Michael, that's really exciting. I'm really looking forward to seeing a lot more in both obviously in the plaque characterization, but also how that then relates to some of the pericoronary measures. I think that'll really lend a lot of insights into the biology that you can't really, unfortunately, we're not really able to get direct coronary plaque immune cells too often. So I think the more we can have imaging markers that get at some of these active processes, the more insights we're going to be able to derive.
A great discussion. Before we wrap up, I would like to just get a feeling from both of you. We're not going to serve as a 3-person guidelines committee, but do you feel that the data we're seeing thus far from REPRIEVE and this important substudy would indicate that we should be using statin therapy more liberally in individuals with HIV?
Yeah, I'm not sure if I should comment on this because I know there's several active discussions now. Also, of course, a radiologist, I don't prescribe statins. My feeling, though, is that based on the data on REPRIEVE, it's likely that guidelines committees will support pitavastatin in people with HIV. It may be based on a different ASCVD threshold than we included in the study when you look at the number needed to treat, but I think that is coming.
Okay, I think that's politically correct. Matt, what's your take on this?
Yeah, I'll be maybe slightly not less politically correct, but maybe a little more expansive. So, Michael, I agree with you. And I think the key questions are, number one, how class-wide of an effect is this? Will recommendations extend to statins beyond pitavastatin? And I think the answer is likely yes. Pitavastatin's more of a kind of moderate intensity statin. And I think having more flexibility to do higher intensity when needed is going to be important. And there have been a lot of studies now on statins with respect to other antiretroviral medications. And there is some caution that needs to be exercised, but increasingly there's reasonable observational evidence that other statins like rosuvastatin and atorvastatin are also reasonably well tolerated in people with HIV. But then I think the real question is, when do we start and how do our time horizons change? Because in the general cardiology and preventive cardiology field, so much of what we think about is 10-year risk. And a lot of that's based on the calculators we have, the observational studies that inform kind of our effect estimates of the different exposure variables that go into the calculators. But the question is, in HIV, if we're seeing ASCVD earlier, if we're seeing plaques begin to get a foothold at an earlier phase, and then ultimately have many decades of plaque continued progression and vulnerability, how do we think about the time horizon? Do we think lifetime risk? Do we think different time thresholds than a 10-year risk threshold? Do we change our risk estimates, knowing that people with HIV in general have about a 1.5-fold higher risk for ASCVD than people without HIV? I think it's a lot of challenging questions. And ultimately, a lot of it is probably going to look at potential benefit weighed against any potential harms, and then also just individualizing the discussion and really making a thoughtful risk-benefit decision that's informed by as best of a precise calculation as we can get, which I don't think our calculations are going to be perfect in people with HIV, but then also placing that in the context of polypharmacy and how do we prioritize statin therapy versus other therapies that are meant to, obviously address underlying HIV, antiretroviral therapy being key, but also other components of premature inflammaging in people with HIV. So I think a lot of interesting questions. My instinct would be this certainly moves the needle towards more statin therapy in people with HIV. How much more, how early, I think that still remains to be seen.
Well, thank you. This has been a great discussion, Michael and Matthew, and certainly underscores that as we gain more knowledge, we also begin to ask more questions. So I'd like to thank Dr. Michael Liu, Dr. Matthew Feinstein for being with us today. And thank you also for listening to this very intriguing podcast. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening. And thanks again to Drs. Liu and Feinstein.